Okay, so I want to get started with just talking about fluid and electrolyte balance. I know you can't really see that very well, but there's fluid balance and then there's electrolyte imbalances. Many times these kind of get intertwined a little bit, and we're going to kind of discuss a little bit about that. But first, let's just talk about fluids. Where do fluids go? How do fluids help us? So in our bodies, we have two compartments where all of our fluid is going to be. It's going to either be in one of these two compartments. So it's either going to be intracellular, so that means it's inside every cell in our bodies. So that's what gives our cells the plumpness, and our bodies are pretty much made up of all cells. So this is the fluid that's inside those cells. This makes up about 2/3 of our total body fluids. So this is inside that cell. Inter means inside. And then we have extracellular. Extra means outside. So these are the water that's outside the cell. So inside the cell is the water, and then we have water outside the cell. That's going to be extracellular. And where do we find that? We find that in several different places. We're going to find that in our bloodstream, in the plasma. We're going to find it between the cells. So we have all of our cells that are packed tightly together, but there's fluid that runs in between these cells, and that's called interstitial spaces. And then we have lymph. We have a lymphatic system that kind of runs parallel to our blood vessels, and that lymphatic system also has fluid inside it, and that fluid is called lymph. Then we have what we call transcellular, and that's where we have it in the cerebral spinal cord, and we have fluid around the heart. And those are just extra fluids that we can have. But the main ones are going to be your plasma and your interstitial spaces. So if you see a patient and they're really swollen and you're pushing on their legs and your fingers are staying down inside there, that means that sometimes people will refer to some of that as like third spacing. So this is where it third spaces into another space. Okay, if that kind of makes sense. So you may hear that term used every now and then. Okay, so first thing we're going to look at is not enough fluid. Okay, so how do we get into a situation where we don't have enough fluid? Well, we're losing body fluids. Either we're not taking in enough intake, drinking enough, getting enough volume that we depleted our stuff. This might be somebody who has been vomiting, diarrhea. This might be somebody who is hemorrhaging. So we're losing those body fluids. And it could also be the loss of both water and electrolytes. So we have a couple of different ways that we look at dehydration. And I'm not going to really get into it because it's a little bit more complicated. But when something is isotonic, if something's isotonic, what it means is it is balanced. So when something is balanced, that means the fluid's not going to shift anywhere. It's going to stay in its space. And so where we really like our fluids to be is in one spot, and we like our electrolytes to all be in a certain level. And if all that is happening really good, we're in an isotonic balance. Sometimes we can revert into a hypertonic balance or a hypotonic balance. And those do change what we have to do for our patients. But if we have somebody that's losing both water and electrolytes, that's going to be more of an isotonic thing because they're losing both of them at the same time. Okay, so just not enough fluid. So we are in a fluid volume deficit. We do not have enough fluid. So fluid volume deficit. What happens? How does this happen? Well, I kind of mentioned a minute ago that that would be excessive fluid loss. So we've got vomiting, we got diarrhea, we got hemorrhaging, we got burns. Because what happens with a burn victim, if we have a burn, somebody who's burned, sometimes that fluid can't stay in those cells. And so it comes out of those cells and it third spaces out. And so we can put all the fluid back into those individuals we want, but it's not going to stay in that space. It's going to come out because it doesn't have the skin coating to keep that fluid in. Decreased intake. So somebody who's not taking enough. So let's think about somebody who's NPO, somebody that's been in the hospital for 3 days and we haven't given them anything to eat or drink for 3 days because we've been waiting on a test and it keeps getting canceled every day, but we keep our patient NPO. So they're not getting enough fluids. So that's one way. Another way would be somebody that is confused. So some of your dementia patients, some of your elderly patients that are super confused, they may not remember to take drinks. So therefore, it's really important that we make sure that we're offering those drinks to our elderly people, or they don't have access to fluids. So think about your elderly person that maybe's had a stroke and they're having difficulty swallowing a little bit, and we're not going into their room frequently, and so we're not offering them drinks. And all we've given them to drink today was maybe 4 ounces of fluids. So 4 ounces of fluids is 120 mLs. And we know what people should be getting in a day is 1,500 to 2,000 mLs. So we're definitely not giving them enough. So they're going to be in that fluid volume deficit category. And then, like I talked about a minute ago, that third spacing. This is where the fluid shifts into the tissues. So we get fluid shifting from, instead of interstitial, we get fluid shifting into our tissues. So the tissues get swollen. The fluid goes into the abdominal cavity and it causes the bellies to get big and kind of bloated looking. So they're deficit, but the fluid has just shifted, and we need to shift the fluid back into that cell. And we're going to talk about how we do that. And sometimes that is going to be based on electrolytes. This is just explaining what a deficit is. Okay, so what would you assess if you are taking care of a patient that you think has a fluid volume deficit? What are you going to see? Okay, so if I have a patient that has admitted to the hospital today and they weighed 136 pounds, and I've had them in PO for 4 days with no fluids, minimal IV fluids, and their body weight has went down to 124 pounds. Well, that'd be a little drastic. Let's say they go down to 133. So they've lost 3 pounds. Did they really lose 3 pounds of fat? Probably not. They've probably lost 3 pounds of water or fluids that we're not giving them. So what would you look for? What would you assess? You're going to look, is their skin dry? Do they have poor skin turgor? So when you pull up on the skin and tent it up like that, it should fall right back down. If it stays up, that tells us that there's not enough fluid. Dry mucous membranes. A lot of times babies, if they're dehydrated, you won't see any tears. They will have decreased urinary output. So you're going to be looking for that in your patients, that decreased urinary output. Or it's going to look super concentrated and it's going to smell very ammonia-y, because they don't have that extra fluid in there. A lot of times their pulses are going to be kind of weak, so you're feeling them and you're like, ooh, that's really weak. It might be kind of thready. Their blood pressures are going to be a little bit lower. These individuals will, when they stand up, they're going to get a little bit of that orthostatic hypotension. They're like, ooh, I'm a little dizzy. And they're going to get increased heart rate. They're going to get an increased heart rate because their heart says, hey, I'm not getting enough fluid to push around your body, so I'm going to have to increase my heart rate to get that to happen. So it increases that heart rate and causes that pulse to be thready and a little bit kind of weak. A lot of your individuals that get really, really dehydrated are going to get confused. So sometimes if you have an elderly patient that comes in with, like a onset of altered mental status or something, or they become confused, sometimes this can be dehydration. Sometimes it can be related to the urinary tract. So dizziness, fatigue. So some of the things that we're going to look for, how do we know that they're dehydrated? Well, we're going to look at a couple labs. There's no way to, obviously we can look at what is obvious, the dry mucous membranes, the decreased urinary output. We can look at the tinting of the skin. We can look at those kinds of things. But the labs are going to tell us a lot about what that patient is. So if we do a urine dip on that patient and their specific gravity is over like 1.030, or it is 1.030, that's going to tell me that my urine is very concentrated, that we are dehydrated. So if you're looking at specific gravity, I you probably haven't learned this yet, but if you use a dip, you dip it into the urine and you read it on a stick. And it's going to kind of tell you what their specific gravity is. Normal specific gravity, I call it, it's 1.005 to 1.030. So the higher that number is, the more dehydrated that they are, the more concentrated that urine is. And many times, if they're this dehydrated, you're going to see a sodium problem. And I'm going to talk a little bit more about sodium in the sodium chapter. So we're just talking about deficit right now, just not enough fluid. So what are you going to do with this patient? So I got a patient, they don't have enough fluid. So you're thinking, okay, well, if they don't have enough fluid, I got to give them some fluid. So that's what you're going to be thinking. So the best thing that you're going to do is you're going to give them fluids, but you're not going to be the one giving them. Who's going to prescribe the fluids? The physician's going to prescribe the fluids. You will administer the fluids. So you're going to follow that doctor's order and you're going to do the fluid replacement. But you're also going to be monitoring their vital signs. You're going to be seeing if their confusion is getting better. Is their pulse getting better? Is their pulse going down? Is their blood pressure improving? What is their neural status? Is the sodium level going up or down? What is it looking like? So, and we're going to give them lots of water. Or we're going to give them something called a hypotonic IV solution. And I'm going to explain that here in just a little bit as far as the 3 types of solutions that we give to patients. Okay? Now, a lot of times with our patients that are dehydrated, that are sick, sometimes we will restrict their sodium intake. Because one thing that happens, and this is just a little acronym that you can remember, sometimes we restrict that sodium because I use the analogy, I don't have a chalkboard to show you this. Hopefully, if you remind me, I can show you this in class. But when we have sodium, and our body's made up of mainly water. So sodium is a salt. And then we have our water over here. So wherever the salt is, the water's going to follow. So if you eat something that's really salty, you're going to get super thirsty. So you're going to be increasing that water. So I call salt Susie salt. And I call water Willie water. So when you have Susie salt and you have Willie water, Willie loves Susie. So wherever Susie goes, Willie's going to go, okay? So that means that if in my bloodstream, when we draw our blood, is there a way to draw blood out of your cells? No, there's not. So we have to draw blood out of our veins. And our veins, we know, is that extracellular fluid. So if we have extra salt in my bloodstream, I have a lot of salt in there, where's Willie going to go? Willie loves Susie, so where's he going to go? Water's going to pull out of those cells, and it's going to go into a different space because it's going to try to get to Susie, okay? So what's going to happen is our cells are going to shrink, and they're going to get real tiny because they don't have any water in them because that water has been pulled out because Susie's in the bloodstream, and it's trying to get in there. So Willie's going to follow that Susie. So we're going to restrict that sodium so that water doesn't pull out of our cells, because we call that cellular dehydration, and our cells get really wrinkly and yucky. So we're going to give them what we call that hypotonic, or this hypotonic. So if you think of that O in hypotonic, we're going to blow the cells back up. So what we're going to do is we're going to give them a hypotonic fluid. So we give them that special kind of fluid, and it's going to push that water and make it go back to those cells. Okay, so that's what it's going to do. It's going to push that water back into those cells. So that's why we give them that specific kind of fluid. Okay, and that's important because we don't always use hypotonic fluids. We only use that if they have cellular dehydration and there's a sodium problem involved. If it's just that person has been hemorrhaging and they've been losing everything all at one time, we're not going to give them that kind of fluid because their cells are okay. Their sodium's okay. It's just they're losing fluids. So we're going to have to give them an isotonic fluid so it doesn't shift spaces. Okay, I know that sounds a little complicated. You might have to rewind and listen to that one again. We're definitely going to implement on these people safety precautions because we know it's going to cause weakness, we know it's going to cause orthostatic hypotension, and we know it's going to cause some confusion. So if they have those things, we're going to have to make sure that those bed rails are at least the 3 bed rails are up. We're going to have to make sure our bed alarms, chair alarms, make sure the clutter's gone, make sure everything is close to them, make sure their call lights are by them, move them closer to the nurse's station, whatever we need to do to make those patients safe. And then we're going to educate them on fluid replacement. We got to get this replacement. Hey, we're going to have to start an IV because we're going to have to give you some extra fluids. So that's kind of where this is going to be, where we're looking for that. Okay, so that's going to be fluid volume deficit. Okay, now we're going to switch gears. And now we're going to look at fluid volume overload. So this is where we get way too much fluid in our extracellular compartment. So remember, we the intracellulars inside our cells. This is fluid outside of the cells. So this is fluid in the bloodstream, in the surrounding tissues, in the interstitial tissues, in the other fluid compartments. So this is because we've either drank too much or we can't get it out for whatever reason. So there's lots of different things that can cause us not to be able to get those fluids out. So let's look at some of those. So one is going to be heart failure. So sometimes when our heart is supposed to be pumping and it should pump a certain volume of blood, when the heart is just really tired, or maybe it's large, we call that hypertrophic, where the heart is large, and so the chamber inside the ventricle is real small. So it doesn't pump enough volume, and so the blood backs up. So when we get back up of blood, we get that fluid volume excess because it comes out of the bloodstream and it goes into those tissues. Renal failure. So if your patients can't get rid of fluid, the fluid's going to stay inside the body. Okay, so if you got a patient that is in renal failure and they're not peeing very much, but they're drinking plenty of fluids, that fluid's got to go somewhere. So if it's not coming out, it's staying somewhere in the body. Liver cirrhosis. So what happens in cirrhosis of the liver, sometimes the blood flow actually goes down into the liver. And if you've got cirrhosis of the liver, that means your liver is real scarred and it can't let that blood in. So it tends to want to back up. And so it backs up into the abdominal cavity. So we see that a lot in our patients that have like severe hepatitis. We see that in our alcoholic cirrhosis. We see that in MASH. We see that in other kinds of different kind of liver kinds of symptoms. Or we might have fluid volume overloaded them with too many IV fluids. And I have seen that happen in the hospital where we get a patient that comes in, their blood pressure is super, super low. We use the big guns to give them plenty of fluids to get them hydrated, and lo and behold, we've gave them too much fluids, their heart can't take it, and now we put them into fluid volume overload. So now we have to pull all that off. And then sometimes it's because they've taken too much sodium in, and now it's causing that shift again. Remember, Willie water, Susie salt. So we'll talk more about that here in just a minute. So those are the causes. So when you go in to assess your patient, what are you going to look for? This is why daily weights are so important. Daily weights are the basis of how we figure fluid volume excess or deficits. So if we have a patient that comes in and they're 140 pounds and they've been there for 24 hours and they're 144 pounds, they did not gain 4 pounds of fat. They gain 4 pounds of fluid. 4 pounds of fluid can be a big deal in a person whose heart is already stressed, because it's going to stress that heart even more to increase the pumping, to get all of that fluid pumping around the body. So we're going to see a lot of edema. So this is where you're going to look in the legs and you're going to push down, and your finger's going to go all the way down. You're going to go, oh my goodness, that's really bad. We're going to have bounding pulses, because we have too much fluid and everything's just bounding, bounding, bounding. So we're going to have a +4 on our pulses. We're going to have increased blood pressure because we have increased fluid volume. We're going to have jugular vein distension. So a lot of your patients will be laying there and you'll see these distended veins out here. That's because the blood is pooling in there. So we got too much fluids inside the body and we can't get rid of them. And a lot of times they'll get crackles in their lungs because if the blood can't get pumped out of that, it can't get out of that left ventricle, it's going to back up into the lungs. When it backs up into the lungs, it pushes pressure and causes that interstitial fluid to kind of gather in there. So you're going to see patients that are going to have shortness of breath. They're going to have dyspnea, which is the medical term for shortness of breath. Their respiratory rates are going to go up. They're going to have more difficulty breathing, and they can also get some confusion too. So what labs are we going to look like? How are we going to know that they're in a fluid volume overload? One, we're going to look at their hematocrit's going to be decreased. So their hematocrit may be normal, but because they have so much fluid in that blood vessel that it's diluted in there. So it makes it look like it's lower, even though it's not really lower. A BUN, blood urea nitrogen. If we have a really high BUN, that's going to tell us that they have too much fluid. And we're going to look at sodium levels. And sodium levels are pretty important because we get this a lot too. So if we go to, we're coming into the doctor and they're going to draw their blood. So we draw the blood out of the vein because remember, we can't draw it out of the cells. So we don't really know what's in those cells. Okay, we don't know because we can't see it. The only way that we know is to draw blood. So we're going to draw our blood. And Susie and Willie, so we're going to draw our blood and our salt is going to be low. So if our salt is low, that kind of can mean one of two things. Either it can mean that you have a lot of blood in your vascular system and the salt is diluted, but it can also mean that if you don't have enough salt in this space, we have too much salt in our cells. So where does Willie want to go? Willie's in this extravascular space. Where's he going to go? So if I got more sodium in my cell, my intracellular fluid has sodium, where's Willie going to go? He's going to go inside my cell. So when the water goes into my cell gets bigger and bigger and bigger and bigger, and it lyses or kind of blows up. We don't like to see this happen. That's very dangerous. Sometimes we can get cerebral edema in the brain and we get brain swelling. So we don't want to see that. So remember, wherever that sodium is, that's where the water's going to come. So if we have high sodium in the bloodstream, our sodium's high in the bloodstream, that means our water's going to pull out of our cells. If we have a low sodium in the bloodstream, it's going to push out of there into our cells, and our cells are going to get big, okay? And they're going to get too big. So now, what are we going to do? Well, one thing we're going to do is continue to do those vitals. We're going to look for that decrease in blood pressure. We're going to look for those INOs. Are they peeing out what they're taking in? Daily weights. We always want to weigh them, same clothes, same time, same everything, so there's nothing different. We're going to look at their edema. This is where respiratory status is so important. And what I see a lot in the hospital is a lot of the nurses will go around and they will just barely listen to their lungs. You're going to miss pulmonary edema until it gets really bad. So you can catch pulmonary edema you can catch it early by listening to the bases of their lungs, and you're going to hear those crackles in there. And if you don't do that, then it's going to take more time, and your patients are going to kind of basically start getting way more fluid in their lungs, and it's going to be much harder to treat. So early intervention, early assessment is what's going to be super important here. So now we're going to restrict the fluids. So we're not going to let them have as many fluids, and we're going to also restrict that sodium, and we're going to give them lots of diuretics. Okay, so we're going to give them Lasix, Bumex, all those different kinds of diuretics. Sometimes we're going to give them a hypertonic solution. So remember, the hypo pushed the sodium back into the cell. Now we're going to give them hyper, so it'll pull the water out of the cell into the extravascular spaces, not necessarily the bloodstream, into those intervascular spaces, so we can get that balance again. And then we're going to look at our electrolytes. We're going to look at our sodium specifically, and we're going to teach them about those low sodium diets and what they need to be doing with those. Okay, so I know that's a little bit complicated. Just remember, fluid volume deficit, not enough. Fluid volume excess, too much. And many times sodium will play a part, but it doesn't always have to play a part in this. Okay,